Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm delighted to be speaking to Dr Clare Bannon, the new chair of the BMA England GP committee. In this conversation, Clare sets out her priorities in her new role and her plans to reset the relationship with the government and NHS England. She discusses the committee's key demands, including an extra £40 to £50 per patient in core funding and meaningful GP contract reform. We also explore the underemployment crisis facing sessional GPs, the controversy surrounding NHS England's list clearing exercise, and concerns over single point of access referral pathways. Clare also shares her thoughts on neighbourhood health contracts and where the committee stands on further collective action and a potential ballot on a Plan B option for general practice. I'm delighted to welcome onto the podcast now Dr Clare Bannon, who's the new chair of the BMA's England GP committee. Clare's a GP partner in Barnsley, and she started as chair of the GP committee last month, but has been a member of the committee for just over 4 years. Thank you so much for coming on the podcast, Clare.
Hi, Emma.
First off, I guess the main question is, why did you want to throw your hat into the ring to become the chair of the England GP committee? Why do you think you're the right person for the job at this point in time?
So it was never part of a plan of mine to stand for chair of GPC England, and I didn't initially think about standing. I ended up doing so really just because I always want to improve things. I always want to try and change things. And lots of people had asked me if I was going to stand. I was already a policy lead and I felt that was possibly enough. But when lots of people started encouraging me to do it, telling me they thought I'd be good at the role, my initial response had been, I can't because it'll be too much for my practice. But actually my practice was very supportive as well. So I actually thought, well, I can do this. I've got the right relationships with people across various stakeholders. I've been policy lead in 2 different areas before. I really only decided in May time, so it has been a bit of a whirlwind, particularly in my own head. I think other people kind of see the change as the change, but for me it's been quite a quick thing. But I think I am the right person for the job. I think I've got a lot of experience that I can bring to the role. I've had previous CCG jobs, ICB jobs, and an LMC CEO in Barnsley as well.
Which areas have you been policy leading on for the GPC up until now?
I was previous policy lead for clinical and prescribing, and then more recently I was the new practice business policy lead, which was a new role that focuses on partnership.
And that's actually kind of quite an interesting change in how the exec team of the GP committee is made up now, because alongside your election, there was also election for new deputy chairs. And so yourself and all 3 of the deputy chairs of the GP committee are now partners. I mean, this must be the first time, I think we were trying to work it out in the office, this must be the first time for quite a while that those leadership positions have all been taken by partners. Do you think that's going to be a benefit?
There's definitely going to be benefits. I think there are potential risks as well. I think our success will be measured by what we achieve for all GPs across England. I think it's really important to recognise that around half of GPs in the country are sessional GPs and aren't partners. And I think it's really important that they don't feel disenfranchised by the fact that all of the officer team are partners. The benefits are that we are a brand new team. We do have a diverse professional background. We've all done lots of different things. We all want to make sure that English general practice gets back to where it should be. And we do have slightly different views, but we all want to listen together, make sure we really bring the committee with us and the profession with us. The makeup of the committee is more reflective of the broader GP community in that there are 50%-ish that are sessional GPs. Also going to be working really closely with the new sessional GP chair, Lucy Jane Davis. I've already met with her and we've already talked about what our shared vision is and what things we think need to happen for the benefit of sessional GPs as well as partners. As long as we work together really closely, there shouldn't be any issues from a sessional perspective.
What would you say to GPs, those sessional GPs or salaried GPs who are worried about representation? Do you think you've kind of addressed that with this close relationship with the sessional committee?
I think that's going to be really critical. I think sessional GPs need to feel like their voice is really loud. We need to fix the underemployment crisis, which, let's face it, is completely bizarre. We need significantly more GPs, and yet we've got GPs struggling to find work. We've got patients with no appointments. It doesn't make any sense at all. We need to make sure that sessional terms and working conditions are better than they currently are. We need to make sure that their pay is better. I mean, we've got too many GPs working close to full time on just levels of pay that no professional in this kind of role should be getting. We need to make it clear that they're deserving of the same professional dignity that we all should be expecting. We're going to have some really shared asks of the government in terms of core uplifts to funding that enable GP partners to pay sessional GPs better for the benefit of all GPs in the country. So I would reassure sessional GPs that we are building that relationship with the sessional committee. We are going to make sure that all our strategy brings in our sessional colleagues so we can move forward together.
That's a really good point, because obviously there's a whole new leadership team of the GP committee, but there's also obviously all these new people now in government as well. So it's basically a completely new set of relationships, new Prime Minister, new Primary Care Minister, new Secretary of State. The past couple of years have been characterised by quite a fractious relationship between the BMA and the government. This is obviously a chance to reset that relationship. How are you going to approach that?
I think there's a huge advantage that we're a new team. We've got a new government. So it's a really golden opportunity to reset the relationship and make sure that our discussions are collaborative and that they're genuinely bilateral and going both directions. I've got lots of relationships with NHS England from both regional work and my policy lead work, as well as relationships with people like DWP. We've already had several conversations with NHS England. We've written to Secretary of State for Health, and I think we're in a really good position to move forward. I think the government will see it as positive that we can move forward with that reset. And I think it will put us in a much better position than we were last year going into negotiations. I think we're very different personalities to the previous team. And my hope is through our personalities, we can get the best out of negotiations and out of other people. I think I can make clear arguments to the other side, make sure they hear the evidence that is genuinely so strong about what needs to happen to improve things for general practice.
In a recent update to the profession, you said that your initial asks from the government would be an additional £40 per patient and GP contract reform. And you touched on there earlier about the fact that some of that money you're asking for would be tied to pay for salaried GPs. What are you going to actually be asking for when you're speaking to the government?
Well, I think it's not just about what we're asking for. I think when we're speaking to government, I want to be talking to government about what we can do to help them solve the issues that they've got and patients have got. So the reality is government wants to make sure that there's good access. That's something we can solve as GPs. They want to make sure through the 10-year plan that there's more preventative care, more proactive care. That's something we can solve as GPs. But in order to do that, we need the funding. And that's the case we're going to be making. All of the evidence points to the fact that GPs can solve many of the problems of the NHS, and actually that funding general practice better will give a better return for the government's money than funding other parts of the NHS. So we know that there's a lot of health inequality and that needs tackling, and we want to ensure there's equitable distribution of funding so every practice can deliver the same kind of service. GPs genuinely have the answer to some of the biggest social health problems facing the nation, and we need to re-establish that faith that GPs are part of the solution, not part of the problem. So hopefully through doing that and showing the evidence that we can actually solve some of their problems, we should be able to get the funding.
Collective action this month is focused on writing letters to MPs and a petition. Is that a key part of this strategy for influencing the government?
So I think it's important that we bring patients with us. You know, they're at the heart of everything we do. And at the end of the day, that's part of the reason we're focusing on this as collective action. But it's also because we didn't want to escalate significantly when we've got a new government and we've got a new team, and we actually want to have meaningful engagement with them and meaningful discussions rather than escalate too quickly before we've had a chance to see if that reset and that relationship is able to improve things for our patients and improve things for GPs and the GP contract.
Have you had any discussions with anybody yet, or is it too soon? I was just wondering if you've got a sense of whether they might be a bit more receptive to some of this.
Personally, we've had multiple discussions with NHS England already. There are positives in some of the things that they are saying. The BMA's also had an initial meeting with Yvette Cooper, and she's been really clear about what GPs are wanting and what GPs need moving forward. But it's still too early to say whether they're coming to the table with something significantly different for GPs that's going to make the change and the improvements that we need to see.
In that update, you've said to the profession originally, says you'd be also asking for, GP contract reform. What do you mean by that? Do you want a completely new GP contract, which was one of the aims of the previous GP committee leadership, or is it just tweaking what we've already got?
Given it's nearly 22 years old, we do need to relook at the GP contract. There does need to be some streamlining. There's too many bolt-ons. It's become really complex. There's too many locally commissioned services that end up being quite a mishmash. It feels quite inefficient that there's a mix of local and national commissioning. There's too much of a postcode lottery for too many patients. There's too much variation from place to place. I don't think we necessarily need to rip up the GMS contract, but I do think we need to go back to first principles. We need to be clear about what general practice should and can deliver, and we need to see what agreements we can come to. So I wouldn't say I'm pushing for an entirely new contract, but we definitely need some contract reform that simplifies things and makes things clearer for local systems about what GPs can and can't deliver. Local GP practices want to ensure that we're providing all the services that patients need. We want to manage long-term conditions better. We want to ensure continuity of care. That's something that can't be delivered elsewhere. That's something that comes through the GP practice contract, and nothing we do makes us want to lose that. That's really key to all of our GPs. So we're quite concerned about some of the at-scale models, because doing general practice at greater scale can remove that valuable doctor-patient relationship that's built up when we care for patients over generations. What we're really clear about is GPs must remain at the heart of delivering and coordinating any of the patient care from any care pathways that they require.
Aside from streamlining that, is there anything else you would like to really see as part of an overhaul of the contract?
I mean, the main things are very much about being really clear about what GPs are responsible for with all these bolt-ons.
Yeah.
The fact the contract isn't overly specific is positive in some ways, because when a patient comes to see us, the last thing we want to do is say, no, we can't do that because of our contract. That doesn't work for anybody. It doesn't work for GPs and it doesn't work for our patients. But actually, that is the situation we're finding ourselves in far too often. Take things like the tirzepatide and weight loss injections being added to QOF. That doesn't really work for patients if the funding doesn't follow it. We've seen huge amounts of left shift of workload without the funding following that. And we really need to be clear that, where we've had that workload shift, and that's why we're asking for £40 to £50 per patient, because we've already had so much of that shift. GPs up and down the country are struggling with whether they should or shouldn't be doing work. We need that to be clarified, and we need that funding to allow us to do some of that work where it's appropriate.
I saw some headlines this morning in the Times about GP partner pay, and there was a comment from you in there. And perhaps, one of the reasons we've got to this point where the GP contract is all so complicated is because governments have often been quite reluctant to put lots of extra money into the partnership model where, partners can effectively decide what they want to do with that money. And ministers, want to know what that money's going to deliver. So that's why it's often been attached to specific things. How can the BMA GP committee address those concerns from ministers who may feel that GP partners see this as an opportunity for a pay rise if more money is put into the core contract?
The contract itself obviously can help the government to do that.
Yeah.
But I would also say that the Health Foundation report that you're referencing, which is where my comments kind of come from, actually does show that since the 2004 contract, there hasn't been any uplift above inflation over the last 20 years for GP partners. So whilst there are a minority of GPs on high levels of earnings, the majority of GPs are not on those high levels of earnings. They're on much more modest amounts. The reality is we need to reflect that back to the government, that actually any additional money that has been put in over the last 20 years hasn't resulted in GPs earning more. GP partners' income has actually remained very stable. If you think about the way GPs are funded, that makes complete sense. I think it's by putting in contractual levers and making sure that the funding does go to employing more staff, employing more GPs. But there's lots of ways we can do that. And we just really urge the government to talk to us about it, because we are happy to work with them to find a way that ensures we can have more GPs. Most GPs aren't after increased earnings. Most GPs are after a better working life, an ability to care for their patients more effectively. They're after the ability ability to not be faced with 150 online consultations all in one go with no additional resource to manage those. I think that's what we need to reassure the government of, and we need to have that negotiation that gives them the reassurance that that money isn't going to go directly into partners' pockets. It's going to go into building stable partnerships that are able to give the care to patients.
Scotland, they secured a new deal relatively recently, which was all based on increased funding for employing more GPs. Is that something that you'd back in England as well?
I think it's something we would definitely be happy to discuss and keen to talk about. My only concern is that core GP funding has been eroded over recent years. All additional funding for years now has been going into the PCN DES.
Yeah.
And the problem with that is it reduces GP's ability to innovate. It reduces GP's ability to be nimble and to do things differently and to actually choose the best way of providing care. So what I don't want to do is tie GPs into having to do things only one way. We do need to restore GP funding. So I would need to be clear about the exact way in which that happens. But I think the principle of more funding for more GPs is absolutely something I would be very supportive of.
Obviously, the other thing when we're talking about funding is the Cahill funding formula. We know that the government commissioned a review, and it probably has the findings of those reviews sitting somewhere in the Department of Health. The BMA obviously hasn't been involved in that process so far. It's really widely accepted by almost everyone that funding formula is out of date. Will you be pushing for it to change? How do you want to see it change?
The GPC England Committee absolutely recognises that the practice funding allocation formula is currently based on health census data from the late 1990s. So we absolutely need to bring it up to date to ensure there's fairer distribution of funding. The Health Foundation report shows that actually the most deprived areas are not receiving the level of funding that they require. We absolutely support there being some changes to Cahill. My big concern is that can't happen without an increase in overall funding, because any changes to the formula risk destabilising practices unless there's an overall increase. Every practice needs to receive the funding it requires to serve its registered patient population. So what we'd like to see is a levelling up, not a levelling down. Any change to Cahill needs to start from the premise that no practice will see a reduction in income, and actually it needs to be new funding that allows us to do that levelling up exercise and allows us to ensure that those practices that are struggling the most get an uplift. But we know no practice isn't struggling, so we'd like to see everybody getting an uplift, but some practices getting an uplift more than others depending on a revised type Cahill.
The challenge is the money's only there if ministers are prepared to provide it. And obviously the government already has kind of indicated that its big priority is going to be social care. I mean, do you think they're going to be quite challenging discussions that you're going to have with ministers over the coming months?
I don't doubt that there'll be challenging discussions. We are hearing from NHS England that there is a very clear view that funding needs to move from secondary care to community care. So that doesn't necessarily mean reducing the spending in secondary care, but what it might mean is that any increases need to disproportionately go to community care and specifically to general practice over the next few years. So that's what we would like to see, is actually any increases in NHS funding, more of that coming to community care. And NHS England has indicated that that is the direction of travel. That is where they're looking to move towards. So whilst I don't doubt discussions are going to be really difficult and it's a really tough economic climate, all of the evidence is so clear that actually by spending more in general practice and wider primary care, but spending more specifically in general practice does actually reduce the costs for systems overall. I think that's the arguments we need to be really clearly making. That's the way of solving the problem, not just for GPs and our patients, but actually for whole systems and for the NHS.
One of the things that is likely to be one of the early things that could come out will be the new workforce plan, because they've been working on that and there's been various leaks in the national media about that. And the things have suggested that there is going to be a big focus on growing the GP workforce when it comes to the medical workforce, what I'm talking about, as opposed to growing the hospital workforce. So, that would be a positive sign that things are moving in that direction if that workforce plan says that, wouldn't it?
We all know we need significantly more GPs. We're losing too many. So obviously retention is a huge issue, as well as recruiting GPs in. I think we
Yeah.
absolutely have nowhere near the number of GPs we want. We talk about places like Australia and they've got, 2 to 3 times more GPs than we've got in this country per head of population. And actually every GP practice thinks what they could do if they had 1, 2, 3 more GPs. And that's what we'd like to see. We'd like to see every practice having more GPs. So I'm really hopeful about kind of any workforce plan being really clear that we need a significant increase in the number of GPs. And then we really need to work with government to make that a reality. Because it's been so long we've been promised 5,000 extra GPs.
Yeah.
It's just continued not to work. As much as figures are changed and kind of different GPs are included to make those figures look better, the reality is we don't have more GPs than we had a decade ago.
Obviously, aside from all the contract and funding, there's a number of kind of immediate things going on that are also affecting the profession. So I thought it would be good to look at some of those. I mean, the first of those I wanted to talk to you about was list clearing, because this has obviously been a massive problem and it looks like it's going to be ongoing for quite some time. What do you want to see happen around list clearing? Obviously, some practices are facing quite significant loss of funding because of these patients being removed from their lists. What do you want to see happen with that?
So we've had several discussions with NHS England about this. Their preferred term is list validation.
Yeah.
And we do share the principle of ensuring practices are paid fairly for the active patients that are on their registered list. But we have asked for a pause in the process because we do feel it's too aggressive. We feel like the numbers coming through are too high. We don't want to see practices paid for work they're not doing, but equally we know every single practice in this country is struggling at the moment. All practices are feeling intense financial pressure. Practice staff are having to spend hours re-looking at these FP69 forms that are coming through and trying to decide if patients should or shouldn't have been removed, whether or not they're still in the area. Because of that, we really need to ensure that the funding that is lost from practices comes back. We've been really clear that any funding in year and going forward needs to come back into core contracts, because this isn't funding that practices don't need. This is very much funding that practices need. But we've also been clear that whilst that may need to be distributed fairly across practices, because there will be winners and losers from the list validation process, the reality is no practice can be destabilised in the short term. We need to be really clear about that. So whilst practices over the longer term may be able to change their mix of staff, over the short term that can't happen. So we need to ensure that any practice that's seeing a significant sudden drop is not destabilised. So we've been really clear about that. We're still having discussions with NHS England about what that can look like for practices to ensure no practice loses out.
There was a suggestion the other week that money, which is going to be quite a significant amount of money that comes from this exercise, NHS England said it will go back into general practice, but there was a suggestion that it could be used for GP premises, but it's hard to see how that could be redistributed fairly. Because as you say, many practices will have done all their budgets for the coming year based on the patients they expected to have on their list. And now they're suddenly finding they've got thousands of patients less or hundreds of patients less than they thought they were going to have. So that's a real problem for them.
Yeah, it is absolutely. And whilst I think it would be difficult to guarantee that any process is going to completely solve that, I think we need to be really clear that any practice that's seeing a significant increase needs to be supported. We're trying to speak to NHS England to ensure that that happens. Any practice that is seeing huge drops in numbers of patients, some of that funding does need to be used to make sure that those practices are not in the short term left vulnerable, unable to continue paying their staff, having a detrimental effect on the other patients in their practice.
Obviously, the other thing in a recent update you sent to Profession you talked about was about referral pathways and about the fact that it was really important. You wanted guarantees from NHS England that they were sending proper guidance to hospitals that GPs should be involved in discussing those referral pathways. We're obviously talking about advice and guidance, single point of access. What do you think needs to happen with that? Are you really worried about how the use of advice and guidance is being ramped up in the NHS?
So obviously, as per Amanda Doyle from NHS England's letter to the press in April this year, she was really clear that the referral thresholds shouldn't be being changed and that GPs do retain the right to refer. Obviously, we're hearing reports up and down the country that there are still concerns from GPs. So we've been really, really clear as the new GP England leadership that we want really clear guidance going out to ICBs that's very clear that local GPs, GP leaders, including LMCs, are involved in the design of all pathways at the outset. And we would encourage any area to ensure that that's happening. As LMCs, do make sure that you're recommending to your GPs where pathways haven't been agreed, that they don't need to follow those pathways. Obviously, sometimes they're helpful, sometimes they're not. It remains to be seen exactly how this is going to be implemented. We're really keeping a close eye on this and very keen to hear from GPs from areas where pathways are being put in place that are not helpful and that have not been agreed by local GPs and local LMCs, because I think that is incredibly important. But NHS England are looking at that guidance. We are inputting into that guidance. So hopefully that will be out in the very near future and make things much clearer for secondary care colleagues and ICB colleagues about how these pathways should and can be put in place to benefit general practice as well as secondary care.
You talked about the fact that if you didn't get sort of assurances around the funding from list clearing being redistributed and this kind of clear guidance on single point of access, you were prepared to take strong collective action. I mean, what do you mean by that? Do you think the steps that GPs have been taking up until now have not gone far enough?
I think there's an awful lot more we can do. Obviously, GPs generally don't want to be taking collective action, but we can see that the viability of general practice is just being taken away. And if things like single point of access and list cleansing worsen things going forward, we're really forced into taking action. Anyone who wants free at the point of use general practice to remain in this country needs to be listening to their GP, because what we're saying very clearly is we cannot carry on with the funding we've currently got. You look at the way dentistry's gone. It's awful. So many patients unable to get a dentist, so many patients unable to get the treatment they require. People really need to grasp that and actually support their GP in making sure that we can get the funding needed to continue to give the care that our patients need. So in terms of collective action, I think we have got a long way further we can go. We've got some clear thoughts about where we could go next. I don't want to overly preempt that because we're still in the phase where we're discussing with NHS England. We're waiting for government to come back to us with positive thoughts about where we can move forward and increase funding for practices. We're waiting to hear what's going to happen. NHS England are working with us around single point of access and are doing the right things at the moment. So that's really positive. And on list cleansing, it remains to be seen, but they are willing to talk to us about ensuring that funding does come back into practice.
One of the things that is potentially on the table, I mean, the committee voted in favour of balloting the profession on a Plan B option that would allow practices to provide more private services. Is that ballot still likely to happen?
Yes, it's been voted for through LMC conference. So I think it's really important that ballot does happen. People in general, the committee, members, the whole profession worry about Plan B because they don't want to privatise general practice. But the GP profession is pretty desperate at the moment. We all want to see the NHS succeed. We want to see it remaining free at the point of use, but that can't be at the detriment of GPs and at the end of the day, our patients, because if we cannot provide the services safely that we need to provide, the NHS is no use to anybody, free or not. It's hugely important, and that sits at the heart of what so many GPs think. But generally, GPs want to support the NHS, and I think that's part of the reason why we end up in the position where we continue struggling on despite the difficulties. But I think Plan B is really important because although we want to keep the NHS, we're currently not delivering the care we want to deliver. We're not delivering the care that our patients want and need. That might be because they end up going to A&E because they can't get an appointment. It might be because they end up paying privately for something because they can't get an appointment soon enough. We're obviously seeing lots of people buying things like weight loss injections because they can't access them. We're seeing the amount of private scans and appointments raise exponentially, despite the fact that most of these things end up coming back to GPs anyway. Plan B isn't about privatising NHS services. It's about looking at alternatives. It's about looking at different strategies we can use. What would good care look like? How much would that cost? We need to have these things ready so we can present it to government. So we've got the arguments. We can enable practices to have an alternative if the NHS were to fail. So it's early days. Plan B does give the profession options. We will be looking to ballot the profession, but exactly what that looks like isn't 100% decided yet. But we will be balloting once we've got all of the information ready for GPs. So it's a meaningful ballot.
So you haven't actually decided what you would ask on the question, because obviously a plan B, it could mean anything from the equivalent of what private NHS services are, or just something that would mean that GP practices could provide more private services for things like, weight loss jabs, where currently people are going and paying, online pharmacies to get those things, whereas maybe they should be able to pay their GPs if they don't qualify for it on the NHS. So have you decided what sort of things, or are those the things you're looking at in this process to building up to doing the ballot?
We've got to make sure that we've got all of the information for our GP colleagues, because it's difficult, because GPs are desperate to keep the NHS. It's got to be something that actually is helpful. It's got to be a viable, credible plan. It's got to be something that supports GPs going forward. We haven't decided exactly what balloting the profession on Plan B will be. We will be working that up. We are already starting that process. We will be coming back to the profession with that.
We ran a poll recently in which half of GPs said that they believed NHS general practice was no longer financially viable. I mean, do you agree with that?
I think NHS general practice is in a really tough position. Everyone needs to understand that GP contract arrangements are far too complex at the moment. Commissioners have spent years making us jump through hoops. We've got less and less funding going through core contract, billions being spent annually on commissioning through multiple national and local contracts. Much more could be done to make sure that those processes are much simpler and more of the money actually gets to the front line. I think whilst it's a difficult question, if all of the practices were completely unviable, they obviously wouldn't be continuing at all. But it's becoming increasingly difficult, and we're seeing practices having to make hard choices about who they employ, how many people they employ.
The other issue that the profession is facing, which is quite significant, is the introduction of neighbourhoods and these new neighbourhood contracts that are coming down the track. You recently produced an update for GPs where you warned that many practices are feeling pressured into signing up to neighbourhood plans with no clear idea about what they mean for their practice or their patient. Are you concerned about what the development of neighbourhoods means for GP practices?
Yeah, absolutely. I mean, when we talk about neighbourhoods, most patients think of their local neighbourhood as being their local GP practice and their local pharmacy. They don't think about it being a much bigger area. And actually, quite a lot of what's being talked about is much bigger than that genuine neighbourhood area. Our concern is that GP practices are being pressured into signing up to neighbourhood contracts too early without sufficient information about what they're signing up to, and that's not acceptable, especially given that NHS England's own consultation on the preferred models hasn't finished yet. Nobody should be signing up to anything until we know exactly what we're signing up to. So I think there's a lot of risk around neighbourhoods. I think there are some potential positives and some potential opportunities, but practices need to be going into any discussions around this with their eyes open and with the full information, which we just don't have yet.
So what will you be telling the government and policymakers, NHS England, about this? What are you going to be arguing for when it comes to neighbours? Because clearly this is the big idea for sorting things out. So, obviously general practice really needs to be at the heart of this, and it needs to not disadvantage general practice. So what are you going to be arguing for as part of that?
GP practices have to be at the cornerstone of neighbourhood healthcare. GPs therefore need to be leading and coordinating their care for their patients. So where there are additional services being brought close to home, GPs need to be involved. We've got a really long history of running services cost effectively. Huge amounts of evidence says that, whereas trusts are often in significant deficits. So Treasury should also be taking note of that and ensuring that they are making GPs at the core of any changes, and that their role is being seen as important to ensure that taxpayers get the service they deserve for the funding.
The neighbourhood contract consultation, obviously that came out a couple of weeks ago. What are you likely to be saying in that response?
Yeah, so we are responding to that. We'll also be writing out to LMCs with guidance about responding as well, to ensure that we're all responding and giving as much back, because I think it's really vitally important that this consultation is responded to strongly, and we have made our response to that and been very clear that GPs need to be at the heart of any changes that are coming forward.
It is quite a complex and kind of technical thing. There's loads of documents. It's kind of quite a difficult thing to get through. But the implications, I mean, obviously it says it's not to do with the core GP contract, but as you said earlier, it's going to have a massive impact on the PCN contract. And as you said, like loads of the extra funding that's come into general practice over the past 6 or 7 years has all gone into PCN. So that would have a catastrophic impact on general practice if that funding wasn't available to them in a similar way as it is now. People really need to be able to understand contracts and contracting, don't they, to respond to it?
Yeah, absolutely, which is why we were sending out some template information to help GPs on the ground and LMCs to respond. It's far too complex. The documents themselves are complex because they're trying to make things too complicated. Yes, a neighbourhood health service on the front of it sounds good, but that should be about services working around and centred around GP practices, ensuring community nursing works around a practice list, ensuring that patients can have services in their local area.
Yeah.
It doesn't need a complete reorganisation. I'm not quite sure why we need 2 entirely new contracts, as well as GMS, as well as PCN DES variations. It needs to be simplified, and we've been really clear in our feedback that actually this is overcomplicating things. We need to be feeding that back across the country. My hope is that government do pull back a little bit from some of the current plans. Obviously, we have got a new government, so it is an opportunity for them to pivot slightly and change. Because whilst we don't disagree fundamentally with the idea of neighbourhoods, we do disagree with anything that takes away from core general practice and doesn't support core general practice and allow patients to have that proper continuity of care with their GP, who's able to see them through time, the whole kind of cradle to grave care. That's really important. And without that continuity, which neighbourhoods may threaten to disrupt.
We've talked about a lot of things today and, they're all really, really important. But if you could sum it up, what's going to be your number one priority as chair of the England BMA GP committee?
So I'm very clear about this, and this is supported by both LMC conference policy and the GPC England committee, is we want to agree a really clear roadmap with government as swiftly as possible to increase general practice investment by £40 to £50 per patient. We know it can't be done completely by April 2027, but we can determine what we will invest in, by when, and what order those investments will come in. So I think it's a really clear ask. We need that significant increase in investment of at least £40 to £50 per patient.
I know it's very, very early in your time in the post, but how do you feel about the future of general practice? Do you feel hopeful?
I do feel hopeful. If I didn't feel hopeful, I wouldn't have taken on the role. Yes. I think we're in a better position than we have been for some time, given that we do have a new government. We've got a government that understands to some extent the necessity of increasing funding into community care and community health in general, and general practice more specifically. So it remains to be seen exactly what that will look like. But I am positive. I do have hope for the future of general practice, and I will be working to secure this additional funding.
Oh, yeah, it's been really brilliant talking to you today, Claire. Thank you so much for coming on the podcast.
No problem. Thank you.
Well, that's it for this week. Thanks so much for listening, and thanks again to Claire for taking the time to talk with me. I'll be back next week for our regular news review, which is back after a break over the summer. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.